To begin, my name is Kara McCanuel. I'm the clinical manager at Baycrest for the Behavior Support Outreach team. I'm delighted to share that a colleague and a friend of mine is presenting today, and the title of her session for the Behavioral Support Rounds is the Virtual Behavioral Medicine, or otherwise known as VBM, a game changer in managing neuropsychiatric symptoms of dementia. So just some housekeeping to begin with, acknowledgement and land acknowledgement. Although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central catchment area behavior support programs operates on the traditional territories of many Indigenous nations, which have cared for the land for thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize the current treaty holders, the Mississaugas of the Credit First Nation. This land remains home to many diverse nations, Inuit and Métis people, and is subject to the Dish with One Spoon Wampum, an agreement to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land today. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. I would like to review some participation guidelines. This session is being recorded, as you would have heard, and will be archived on Ontario CLRI and BSO websites. Your microphone is automatically muted. We will have about 40 minutes of presentation, followed by 15 minutes of discussion and a wrap-up. Please place any questions you have in the Q&A box. If you have questions related to tech support, please message Agnes. So you'll see Agnes with the dog picture on her screen. For those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form, which you will receive after today's session. So without further ado, I would like to introduce our presenter, Laura Petta. She is a social worker by background and currently works as the clinician leader for the Virtual Behavioral Medicine program at Baycrest. In this role, she assists the VBM team, families, and healthcare providers to further support patients with severe neuropsychiatric symptoms of dementia. Previously, Laura worked as a social worker for the BSO Caregiver Specialist Program out of the Alzheimer's Society of Toronto. She advised family and friend caregivers helping a person living with dementia in one of the Toronto Central long-term care homes, connected them with many supports available at Alzheimer's Society Toronto, and facilitated support groups there. Much of her long-term care experience was acquired while working for the long-term care ombudsman programs in both Santa Clara County, California, and when she was program director for the New York City program. So welcome, Laura.
Thank you. Thank you so much for having us today. I'd also like to introduce Fidelma Saraduke, who is the clinical manager for ambulatory services here at Baycrest. So thank you, everyone. Let me just pull this up. Okay, great. So I'm here to talk to you about the Virtual Behavioral Medicine program. I've called it the game changer in managing neuropsychiatric symptoms of dementia. I'm a presenter and I do not have any relationships or commercial interests to share with you today. And no disclosures other than we receive financial support from the Ministry of Health, Long-Term Care, and the OHT. Okay, so for today, these are our learning objectives, and I'm going to speak for a time and probably go through a case and see if we have time for questions at the end. So it should be about 40 minutes, 35, 40 minutes. So the learning objectives for today is to basically better understand when to escalate one of your cases to a virtual behavioral medicine program. Who is going to be appropriate for our virtual behavioral medicine program and who meets our criteria, who to contact when you plan to make a referral to the virtual behavioral medicine program, and who you contact if you are currently a part of a care team or you have a patient who's in our program. Okay, so basically the Virtual Behavioral Medicine program is a partnership between the Sam and Ida Ross Memory Clinic and Behavioral Supports Ontario, as well as the Paul Austin Ambulatory Services. Am I getting that right, Fidelma?
Uh,
It's a long name.
Close enough. It's the Pamela and Paul Austin Center for Neurology and Behavioral Support at Baycrest.
Thank you very much. Okay, and then we have BSO involved in our intake process, the centralized intake team. I'll tell you more about that. And as you know, with BSO, the focus primarily is on non-pharmacological behavioral approaches and outreach. And then we assist with the connections with VBM and all different types of care settings. So the community, long-term care, as well as acute, specialty hospitals, and retirement homes. Okay, so let me tell you a little bit about VBM. So, Virtual Behavioral Medicine Program is an innovative care model for people living with dementia who have neuropsychiatric symptoms of dementia. So, we have this program, and our founder, Dr. Friedman, he also is the clinical director on the 4 West Behavioral Neurology Unit. And I always say that he's always ahead of the pulse, like he's on the pulse of the next big thing. So February 2020, he looked at the wait list for our 20-bed inpatient stay, 4 West or a CAS unit, you might call it different things. And it's a secure unit where we would typically see people with behavioral issues related to their dementia. And at that time, our wait list was approximately 18 months. So Dr. Friedman, before COVID, came out with this model where he thought, okay, I've got to get this reduction down. This is an 18-month wait list at this stage. I'm going to see some of these patients virtually to see if I can help them. Anyway, COVID then hit in March, and I imagine that was a tremendous facilitator for this program. And then he was able to see these patients virtually. That's why I say he's ahead of the game. And he got the wait list down to something like 3 months, which is incredible. So from this, the learning was that this is maybe possible for many of the patients that we see. And what's wonderful about VBM is we're able to see people where they're at, so they're not experiencing distress from being transitioned to a different environment, such as a hospital. And we're able to keep them in their current setting or get the behaviors managed to the point where they can be in the most appropriate setting for them and their caregivers. So let me tell you a little bit about VBM. It functions as a virtual inpatient behavioral neurology unit. Virtual assessments are conducted by our interprofessional team, the VBM team, with patients, caregivers, and their care team. As well, I know many of you are here from BSO services, so of course we would be asking if the person's in a long-term care home that BSO lead is available to help support the call and speak to the behaviors that the patient has. For those of you who are on Loft, what we do, we reach out to the power of attorney for healthcare and see do they give our permission to reach out to any clinicians, BSO clinicians that we want to have on the call too. So that's something I want to flag for you as well, because we look at the whole circle of care and we want everybody to have the same information. So referrals come to us equally from acute care, long-term care, community providers, all over the GTA and actually throughout Ontario. I'll show you a map later, which is just really fantastic. The VBM team follows patients through transitions between care settings, so we reduce the risk of admission to acute care and we avoid ER visits. So Baycrest has capitalized on the experience of behavioral medicine and its relationship with BSO to create this interdisciplinary program that is applicable in a wide variety of environments. So our team, this is our team. I liked that icon, so I put it there. It consists of Dr. Friedman, who's the head of neurology and medical director for the Austin Center of Neurology and Behavioral Support at Baycrest Health Sciences, Fidelma Saraduke, Clinical Manager for Ambulatory Services. We have a neurologist on staff and 2 psychiatrists. And so I want to point out that VBM has grown a lot this past year. And so we've been able to invite some more physicians on, and which has been a great because we've been receiving many referrals, and we want to be able to see everybody in a timely manner. There's my role now. I'm the clinician leader. We have neuropsychologist, Dr. Yael Goldberg. We have Robin Mitchell, who's a social worker here, and she was a social worker for many years on 4 West Unit. We have 2 amazing pharmacists, and the pharmacists sit in the clinics with the physicians. We have behavioral neurology fellows, as well as our 2-star clinical navigators that help receive all your referrals, and we'll get to them later, Varsha and Laura, and administrative assistants who help support the daily function of the clinic and field calls that as they come up, calls and questions. So in our VBM care model, we align people and teams, and we coordinate the resources involved. So that's why I said at the very beginning, we reach out to the power of attorney for healthcare to see who's part of the circle of care, who they want to have on the call. So all we really need is a virtual connection. We need someone to show us the patient. So it's very important that we see the patient every visit. And the reason why we do that is because we want to see how the patient is doing on the medications that we've recently prescribed. So the physician may ask them to, do some neurological tests, touch their nose, move their hands around. They always, typically, as long as it's safe for the patient, we would ask the patient to walk because we want to review their gait and make sure that they're very steady. Also, I've noticed that the physicians do speak to the patients and ask them, how are you? How are you feeling? Tell me what you think is wrong. So before they make any additional medication changes, it's really important that they're able to see the patient in the clinic. Now, that being said, we don't need the patient beside us. If you're doing your initial assessment, we don't need the patient sitting with you for the full hour because we recognize that'll make the patient very restless and maybe anxious about what's happening. So typically what we do is we get a personal history and a report from the team who's referring to us. And then what we'll do is we will say, okay, can you show us the patient? So we want to make sure the patient isn't out at a day program or off the unit somewhere else, and that we're able to get to them quickly and do our assessment with them. And then we can leave the patient and let them get back to whatever they're typically doing at that time. Desired outcomes for individuals. So the main one is we see people who have neuropsychiatric symptoms of dementia or responsive behaviors. And we want to get those behaviors manageable to the point where it can meet the care need, like the medical treatment plan for that environment. So if it's someone in the community where the family is really big on wanting to continue to support the person at home, maybe we get the behaviors managed to the point where that person can attend a day program. Give the caregiver a little bit of respite, but they can still live at home with their family. In terms of acute care, we want to get behaviors managed to the point where a person can then be transferred to a long-term care setting. Same with retirement home if that's what's required. Or maybe we get them managed to the point where they can function in a retirement home with a caregiver assisting them, maybe privately. It all depends. And we ask this feedback from the power of attorney for healthcare as well as the teams when we're meeting with them initially. Services and experiences. So again, we really value the BSO non-pharmacological plan. And again, Dr. Goldberg is an expert on this as well. And she's part of our clinic. So I'll get into her role a little bit more later. But we do value the non-pharm approach as well. But there are times, though, that we find that clinicians will come to us and say, okay, we've tried these non-pharm approaches. we need a little bit more. We need some medication also in conjunction with it to help all of this come together properly. We really try to keep regular flow for appointments, and there is an inpatient admission process if needed. So here, very quickly, are some of the behaviors that I know with your being in BSO, you're familiar with some of these. And these are reasons that we would receive a referral. Is the patient hitting? Are they scratching? Are they kicking? Are they grabbing, pushing, cursing, spitting, screaming, throwing things, disruptive noises? Here's some more over here. Do they have delusions and hallucinations that are distressing for them? Hypersexuality, disinhibition. We want to make sure that our care providers are safe. So we want to talk to you about, is there a threat to the patient themselves or to others? And then we also, when we're looking at referrals, we look at how is the caregiver doing, if this is somebody in the community or if they're in acute care or retirement home. Is the burnout very high? And what resources are in that person's region? We're really lucky in Toronto Central. There's very robust BSO services as well as Central. But I do, as we've been speaking throughout the province, Fidelma and I and Kara about VBM, and Varsha and Laura as well, we've learned that some of the areas don't have the luxury of having just as many resources in one area to support. So it might be more spread out. Okay, and I know everyone in this meeting has seen this heart diagram before. So to be eligible for VBM, the person must have dementia or strongly suspected dementia. They must also have behaviors. And then I have a new, one of our new referral forms on here too, and we can walk through that a little bit. And I can show you what we need to see. Excuse me, the person must have, if they have strongly suspected dementia, but there's no diagnosis, which happens sometimes, what we want to see is any tests, any MOCAs that have been done, any MMSE, to give us an idea of what the baseline was and where we're at now. Also, people need to be medically stable to be in VBM. So we want to see that people are, maybe someone's in acute, but they're there primarily for behaviors. They might have a couple of ailments, but nothing that would prevent them from having some medication. It is a pharmacological program, so we want to make sure that the power of attorney for healthcare is enacted, and that they are aware that it's pharmacological and that they are in agreement to using medications, because that is really truly what we're doing at this stage if somebody is coming to VBM. Have we trialed existing resources? So this one, what we do if we receive a referral is we will ask the team, the referral source, what services have been employed. So these might be BSO services. They might be our GMOT partners that are in the community. We also want to know any other physician that might be involved. So this might be a family physician. This could also be a neurologist. So we ask all of that information because when we're sending our dictations out, we want every physician involved, and also we want to send them to the home so they're getting the information as well. I mentioned the POA consent and the SDM consent. And then when you are filling out a CAS application, so an application for an inpatient stay, we see you in VBM first. And that goes back to that what I said at the start of the presentation, because what we found through our work here in our program is that people might be able to avoid an inpatient stay. Okay, and this I will just fly through because I know most of you know it. So here's the client and family. Can everybody see my cursor? No? Yes? This here? Okay. The big green dot at the bottom is the client and the family. And then we go up and we could look at using all the resources on the left-hand side. So that's all the BSO resources. And then looking at using the staff in the long-term care homes, the MRP physicians in the long-term care homes, definitely the BSO leads. In the community, it would be the GP, any care coordinators that are involved in the calls, any services such as my amazing partners at the Alzheimer's Society. And then we would look at the other supports that we can escalate to. So in long-term care or in acute care, we could use LOFT, BSOT, GMOT, PRCs, another amazing resource, and I hope some of you are here today, where the psychogeriatric resource consultants they're able to provide ongoing education relating to some of these behaviors. And then in the community, again, that's BSOT. So this is an outdated one I have here, Kara, because it's all BSOT now, I understand. And then we get to, if that's not resolving things, we can either go to a complex case resolution table and then come to VBM. Okay, so I'm just gonna go to the next slide. This is our new referral form. It's fillable. It's on our website. And I'll show you our website after. One thing I want to highlight, so we want to know if the person is making their own decisions or not, because again, we want to have people who have dementia who are being seen and who are not able to make their own decisions. We want to know who is making decisions for this person and where the patient is at. Is the patient living on their own, or are they in the community with somebody else, or at a long-term care home? It's helpful if you know the diagnosis already. But again, like I said, as we all know, sometimes we see that unspecified dementia, so we might not know. These are all the behaviors that are listed, and again, we have other at the bottom. Most importantly, though, we need a referring physician's signature or a nurse practitioner's signature, okay, as well as their billing number. And then that helps us know who we're sending our timely dictations to. This is our map. So previously, if you've been to one of these presentations, you might have seen that we were focused primarily in the GTA. Now we have some patients in Fort Frances, Sault Ste. Marie, the Ottawa area, Campbellford is another, Owen Sound. So we're growing as far south as Sarnia. And people, what I find most interesting is that acute care will make referrals to us and they will say, we're referring somebody that we've already trialed several things that we've experienced through another patient's clinic. And we've tried those things and we don't know what to do at this stage. So this is why we're referring to you, because you've built capacity for us, and you know, this was someone that we haven't been able to manage. So I think that that's really promising too. I'd like to point out too that we now have a partnership with TRI. Last year, I believe right before I came on in March 2023, there was an agreement signed, and we have a VBM program here at Baycrest as well as TRI, and both teams provide rapid short-term access to specialized virtual behavioral programs as well as managing the behaviors. And again, if you apply to the SDU or to our 4 West site, we see you through VBM first. Okay. you want to go ahead,
In a
Fidelma?
little bit there and just let everybody know that those two programs, TRI and Baycrest VBM programs, are quite integrated, and the access to them is through the central intake office at BSO.
Yeah.
And that is a really great way to ensure optimization of resources, but also that the patient's care needs will be directed to the most appropriate team.
Thank you.
In addition to that, I want to highlight that the virtual behavioral medicine program works in very close collaboration with the inpatient specialty units, such as the behavioral neurology unit at Baycrest, and with the seniors dementia unit at Toronto Rehab Institute.
Thank you. Okay, so some key takeaways that I have here are that we focus on responsive behaviors related to dementia, in particular, especially agitation and aggression, okay? Or any behaviors that are a threat to the person themselves or to others. We have this virtual inpatient neurobehavioral unit. It's essentially a very similar team here in our VBM program that is also on our 4 West inpatient stay. And again, Dr. Friedman is the director of both programs. We're highly successful in reducing the need for admission to these programs. There is a journal article that I will attach to my presentation and give to you, Bianca. I thought about it afterwards. In the Alzheimer's, the Journal of Alzheimer's Disease, where it talks about VBM and how through the trialing at the very beginning, we were able to reduce admission for 60% of patients, and then I believe the 30% still needed to be admitted, but 60% were the ones in that group. I feel like it's probably more after we have looked at this year and all of our numbers, but it is a great program. And what is amazing in dementia care is that we're able to keep the person where they're at and bring the care to them. We have good communication with our referring sources. We say to them, you're welcome to call us anytime outside of the clinic. We always part with that comment. And if you can't get the physician, I strongly encourage you to reach out to me, and I'm happy to support in any way, or our amazing admin. You can reach them, at the main number. We have a 1-800 number for VBM now too, which is really great. We do have short wait times. We try our best. We'll triage who we're about to see. So if it's someone who's in a very dangerous way, we do try to prioritize. We have regular follow-ups, sometimes weekly if necessary. And we say to the team, if you need us before the next appointment, please reach out. But what I'm finding is that teams don't always reach out. And I think sometimes teams just have comfort in knowing that they can call us if they need to. The other thing I really wanted to highlight here is that we support transitions. So I've had one patient I can think of in particular who's been in the community, and we've stabilized them there, and then they've needed to move into retirement home, and so we've had that experience with them there, and we transition and we meet with the team, and I feel like it supports their application if they're involved with VBM as well. And then I've had that same patient go to acute care because he had an issue, and so we saw him there just for a little bit and then he was in a bad way for a bit, not medically stable, but then we came back and we supported a transition recently to the long-term care. So, this is someone who VBM has benefited, and all the while, since he was in the retirement home, there's been a CAS application for this gentleman, but we've managed to avoid an admission because he's responded well to the medications as well as the non-pharm approaches that were recognized. And then I can't not say this last thing without Dr. Friedman knowing. He provides very prompt dictations and faxes the letters right after his clinics, and I know he encourages the rest of the physicians to do the same thing. This is where you can find us on our Baycrest website, and there's a little video here about VBM and about the study that I was mentioning earlier, if you're interested. Now, who you contact. I know this is my third objective in this presentation. So when you send your referral in to the centralized intake office, you will get one of these amazing women, Varsha or Laura, and I'm the other Laura. I always say she's the main Laura. Anyway, so you'll get them first, and they'll triage with you what's going on, who's seeing this patient, what are the behaviors that need to be targeted, and they'll ask you to send all the supporting documentation, and then we will look at very complex cases that we're not sure, is this person suitable for VBM, and we'll get some more background. We might call you a couple of times if we really are trying our best to have them seen in VBM. And this is the three of us as well as Fidelma, if you have any questions about initially being in the program. And then once you're in the program, you would speak to our admins, either Najaha or Nushrat, and they can help you with the day-to-day. And of course, I'm always available for you to reach out to. And Kara knows where to find me if you have any questions. Okay, thank you for my slides today, or for letting me show you my slides in the presentation. And so I'd love to answer any questions you have now.
Great. Thank you so much, Laura and Fidelma. So as you just heard, now we have some time for some questions. Please use the Q&A and or the chat, and we'll keep an eye on that to address any questions you might have. So one question has come through. Can you elaborate on the kind of behavioral assessment done on VBM?
The kind of behavioral assessment. So do you mean by the physician, or do you mean by Dr. Goldberg? Any? Be more specific?
So I'll just jump in there a little bit. First of all, the information that comes in with the referral is really important.
Yeah.
And as Laura mentioned, she will the intake office team will reach out for more information if the initial information is are there gaps. We'd like to know about the severity, the frequency, the type of behaviors that are of most concern, and then of course what has been tried. We have developed in VBM our own severity rating scale for these behaviors that we use to demonstrate or determine progress or lack of progress as the person proceeds through the VBM program. Now, we have a wonderful team member, Dr. Yael Goldberg, who specializes in this area of behavior analysis, assessment, and treatment for the non-pharmacological behavioral interventions. So because we have a lot of different cases and we only have one Dr. Goldberg, we are very circumspect as to which cases we'll ask her to get involved in. And then if Dr. Goldberg is referred a case, she will then do her own specific behavioral analysis assessment that she's better capable of explaining what that is, but it's quite detailed. And so from each visit in VBM to the next follow-up visit in VBM, we need to know the response of the behaviors to whatever medications and strategies have been deployed, and whether we see any movement in the right direction towards better behavior management.
Okay.
I'm just looking, sorry, I
There's
hope I answered
one
that
question.
question.
Yes, so they were asking specifically about the neuropsychologist, which I think you covered, Fidelma. Charlotte asks in the chat box, what is the approximate time from referral to first appointment?
So that varies. You know, when we can see people as quickly as 2 to 3 weeks. And if there's a real danger, I always ask that you flag it for us at intake as soon as possible. And then we can try to see if there's been a cancellation, or if one of the physicians has some flexibility in their schedule that week. And then that way we can try to get people in. One thing I forgot to mention during the presentation is that we typically try to see people in VBM for 8 to 10 weeks first, or 8 to 10 visits, excuse me. And that's because we go low and slow, and we want to see how the patient is responding to the medication. So if we feel though that a patient could be taking a little bit more, maybe they're younger, for instance, then this might be something that we do. Also wanted to highlight what's really interesting about VBM is that we see people as young as in their late 40s, early or late 30s even. I think we have a case and we see people who have Huntington's disease. So we seem to see people that don't necessarily have access to service until they're 65. And when you hear Dr. Friedman speak, he'll say there's no magical number about 65. Aging is a process. And so we start, when we see people who have neurological issues and dementia. So that's something I want to keep in mind too, especially if you're here from an area maybe outside of Toronto Central or Central, because you know the feedback I've gotten from some of the areas that are a little bit outside of this region is that the BSO services or the local services don't start until a person's 65. So what do we do, Laura, if we have somebody maybe with FTD who is much younger?
Well, I just wanted to also add in terms of the wait time from referral to the first appointment. Again, when the referral comes in, it's with the intake team. Now, if the referral has all of the information that's needed, then once the intake team have reviewed that and ascertained that yes, it's appropriate and yes, we have enough information, they then move it on to the clinical side where we schedule. So if your referral is complete and reviewed and accepted, it could take up to about 5 business days for the intake team to complete that cycle. And then we would begin to book. From that point, it could be anywhere from a week to 2 or 3 weeks before you'll get that first initial appointment. And that varies because based on the number of openings we have in our clinical calendars for the various physicians, and exactly how many patients we have at any one time. So to give you an idea, our current active caseload in VBM, the number of current cases that we have is 94. So that is one indicator of how many cases that our team is supporting and managing at any one time.
Yeah, exactly. Thank you for pointing that out.
Any other questions? Again, we do have some time, so feel free to use the chat box or Q&A.
I wondered, you know, if anybody has a case that they want to ask about, and we could sort of go through what some of the steps might be for a potential referral, we could discuss it, because I do know sometimes that
There's a comment.
people will be a little hesitant and say, "Oh, I don't know if I should refer this one," but I really encourage you
Okay,
to
so I see
reach out
one in
to
the
us.
chat from Miriam. Thank you, Miriam. The
Excellent.
question is, have you had any cases with exit-seeking tendencies with agitation, and how did VBM benefit that person in a case like this? Laura, you probably can even think of some examples, but I certainly in the 3 years plus that VBM has been activated, we've had lots of cases with people who are presenting with exit-seeking, agitation, verbal, physical aggression, pacing, repetitive, stereotypical behaviors, vocalizations, yeah, lots of them. And how did it benefit them? Well, first of all, the team, the team will review the medications that the patient is currently taking, both the type of medication and the dosage. They review things like, does the person have sufficient renal function to cope with certain medications? And then they may make either adjustments to dosages or remove medications and add medications. And we have had significant success with those types of symptoms. And of course, as Laura said, we always reinforce then with the caregiving team the recommendations for non-pharmacological management as well, and the strategies.
One, and that's really very true. So I also think that with the exit seeking in particular, so we would look at the non-pharm, but we would also look at where is the patient trying to go? What are the concerns? Are they trying to get away from hallucinations, for instance? Are they trying to, why are they so restless? And one thing that has been really valuable with VBM, honestly, that I have found personally after coming from my last role is, because it's an escalation service, sometimes at this stage, the caregiver and the long-term care home might not be seeing eye to eye on what's happening with the patient. And so if you introduce VBM, caregivers might say, "Oh, you're just going to medicate my parent or my spouse." And I still encourage you to reach out to us if you have power of attorneys that are reticent, because I have met with some power of attorneys, and I think Christina, I don't know if you're here today, you sent us a referral about a grandson who was really reluctant because he didn't want more medications for his grandfather. But what we explained to him, myself and our pharmacist, we met with him in advance and said, in our program, we look at all the medications, and if there's medications on there that we can take away, we will. And then we'll trial medications that we think might be, maybe they're newer medications from when this gentleman had been prescribed these things previously. So we'll introduce that too. Anyway, he got to the point, this power of attorney for healthcare, where he didn't even come to the meetings anymore because he felt so confident that the long-term care home and Christina were going to explain to him what was being done at the meeting. And, everything is done. We make recommendations, but of course, the long-term care home would have to get permission from the power of attorney. But my point is, the first few meetings, he was on that call and he was listening to Dr. Madden, I believe it was, and really asking a lot of questions. But once he realized what our goals were, his hesitation was greatly reduced. So I want to point that out to you as well, because
So Laura, we
again,
have another question.
more capacity building.
Michelle, I think it is. I'm not sure if I can see your full question, but I think I'm reading something like, I have a resident who gets something each time she gets up for meals.
Yeah. So Fidelma later on, she indicates the client gets agitated and screams each time she gets up for meals.
Right. So Michelle, we would look at, as we said, all the medications, all of the triggers. So what is it that is seen to be a trigger? And we would work with the team around what medications need to be changed, adjusted, or added. And then also concurrently, we'll then see what can be done in terms of non-behavioral interventions to make meal time less of a trigger. So it's really a collaborative effort. We're not coming in and telling everybody what to do. We're coming in, I would say, like the guide on the side, as opposed to the sage on the stage. You know, we're there to support people who already know a lot, and we just want to offer some different perspectives and some different ideas about what could be valuable to the situation. I see another one that says, we have a case, early onset dementia, family history of early onset. Her main behavior is physical aggression with personal care, verbal outbursts. She loves to walk and often wandered. However, a recent fall and pelvic fracture has been difficult as she requires a wheelchair with a PASD lap belt for safety. Agitated and screams each time she gets up for meals. Thank you. I think that's Michelle as well. She sounds like one of our typical VBM patients. So if you feel that we could offer some help to the team and to the patient and her caregiving family, then consider a referral.
Oh, I see, Iris, you wrote something here. Thank you. So I've had a case with VBM and is still in a success case through though the person was at CAS and then followed by VBM. That's actually a great point that we missed. So when we have people who are discharged from our inpatient stay, we'll have them back in VBM and we'll help with that transition. So if they're transitioning back to a long-term care home like yours, then we will be able to offer that. And typically it's because the inpatient stay has done such a great job in 4 West, then it'll likely be one transition. However, we would continue to see the patient for as long as needed. And there's one that we have seen recently, and I'm thinking, Michelle, some of the things that they tried, because again, meals were a huge trigger for this patient. They looked at feeding her first, like making sure she was one of the first people to get her meal, and that she had a special place where she liked to sit. I don't know if those are things that have been thought of, but she had like an assigned area. She felt like a VIP, basically. And so these were some ideas that were trialed.
Great. And it looks like Charlotte's going to send a referral your way, which is wonderful.
Thank you.
Any other cases that the group would like to ask about in terms of suitability for VBM or any other VBM related questions?
Well, I'm just going to put my email in the chat here. And if you think of anything at 10 o'clock tonight, you can give me a...
Well, I will reinforce that she'll only answer during business hours.
Yes, I will, but you can send it off when you remember it.
The other thing I just want to again underscore is that VBM does not just accept patients at the age of 65. We do accept patients who are younger. And so, you know, that's a gap in the system. We've seen it in many areas that people develop neuropsychiatric symptoms related to neurodegenerative aging and dementia. And they're sort of falling in between the gaps in the system. And we don't discriminate. We say VBM can help these folks get some support and make their lives better. I mean, ultimately, the goal of VBM is to support all the people working with this population to better support their needs and to try and give the patient experiencing these symptoms and the caregivers around them coping and managing with these symptoms the best life that is possible. And it's a collaborative service, and we love working with teams to support the teams do what they need to do, and the patient and their family members get some relief and some happier days ahead. So if there's not any other questions, we've got 10 minutes left. I just want to make sure that you get a chance to have your questions answered, and if you have any cases you're thinking of, you're not sure.
So our very own Agnes asked a question. Yep. Do you plan to expand or support hospitals across Canada on how to start a VBM?
So great question. Thank you, Agnes. Within our VBM program, we have a lot of activities happening right now. We have a VBM evaluation project. We have ongoing research. We've also made some presentations at various conferences. We also are developing a VBM /dementia behavioral management e-learning platform that we will announce when it's ready to go. So we want to build capacity in the system amongst healthcare providers, and also enhance the awareness of regular folk in what these behaviors mean in dementia. We are fielding a lot of interest from other centers to how they might be able to implement a similar model, both within Canada, within Ontario, and actually internationally. And a team from VBM is heading off to Japan next week to present to the World Neurology Foundation Conference. And so as this program has grown over the last few years, and the impact of it has become more known, we're getting more and more interest to support the spread. And we're very interested in helping this type of model become available wherever it's needed. So yes, a lot of work is happening on that score.
And Fidelma and Laura, there was the request maybe to go over what information you need if there isn't a confirmed diagnosis of dementia. Yeah. So if there's ABI, what documentation would be helpful to supplement?
Yeah. So we've said if it's a known diagnosis of dementia or strongly suspected, and we've had lots of cases referred that would have had in their history, in their medical history, a traumatic brain injury, perhaps substance abuse disorder, alcohol, or others, and also perhaps epilepsy, or some other neurological insult that might have happened in the past. But now the individual is, a few years on, and they're aging, their brain is aging, and the behaviors are becoming a bigger problem to their quality of life and to care. So in that situation, we need to know exactly what are those comorbidities and when do they get diagnosed, what has been happening in terms of that medical care, and then now what are the behaviors of concern that you want VBM to target. And so that helps us to understand whether or not we can actually accept this patient and help the team and help the patient. I have to say that we've had cases. There's one case in particular that I'll never forget. It was a patient who has had a remote traumatic brain injury, had also significant alcohol misuse disorder, had at one time been living without a permanent home, had problems adjusting to a normal, employment situation, and ended up again with a severe traumatic brain injury. So 2 traumatic brain injuries. Ended up in a complex continuing / kind of rehab unit in a community hospital, and was there for over a period of 4 years, and with intermittent readmissions to an acute care center. After 6 months of coming into VBM and working on this with this client and the team, I should say the client had been refused over the 4 years 29 times from long-term care homes. So when we worked with the person and got the behaviors under control to a certain point, we advocated that now might be the time to try for the 30th application to long-term care. And working with the home care coordinators, they were successful in getting that patient accepted into the 30th long-term care home application. And we provided the transition care to the home, and having VBM involved actually helped that home to accept that case. And the case has been there. We haven't heard from them since. Seems to be doing okay. So that's the kind of example of one that really stands out to me. And we've had others. We've had another one who was 5 years in an acute psychiatric intensive care unit in a downtown teaching hospital in Toronto. And after getting involved with VBM, the person was then designated ALC and suitable for transfer to long-term care.
Great.
Now, there are a small number of cases that come through where we will be the ones to say, we've exhausted all our tools here, and we really think this warrants consideration for an inpatient admission to the specialty unit. And we work then with our partners in inpatients to just make that possible, where so that the best efforts have been tried, but perhaps that patient needs a more controlled environment with that special expertise from that team.
Wonderful.
I hope that's helpful.
We only have about 3 minutes time left. So any other chat, any questions, again, please put it in the chat box or the Q&A. We're just getting close to the end of today's session, but might have time for one more question.
I just have a quick comment. If you are currently in VBM and we're seeing one of your patients or your client, please send an updated MAR before we see them in clinic. So we do this to make sure that we know which recommendations were accepted by the most responsible physician or nurse practitioner, and we're able to compare our recommendations with what's actually happening with the patient. So very fast. I just wanted to mention that.
Great. So I don't think there's any more questions. So I'd like to thank everyone for joining us today. Special thank you to Laura and to Fidelma for an incredible session on invaluable service. Just a quick reminder that if you'd like a certificate of attendance, please complete the brief evaluation survey, which will be emailed to you. The recording will be available on the CLRI and BSO websites. And thank you again, everyone, for joining us. Have a wonderful day.
Thank you all for your interest. Thank you, Cara. Thanks, Laura.
Thank you.
Thank you, Agnes.